Welcome to today's event. The Leukemia and Lymphoma Society of Canada is proud to present this webcast onto CAR-T therapy, navigating the Canadian landscape in partnership with Cell Therapy Transplant Canada. Today, we are very lucky to host several guests that will introduce in a few minutes. In this 90-minute live webcast, we'll learn about the CAR-T therapy landscape and its access challenges. We'll hear about the LLSC Travel to Treatment study results illustrated by a powerful testimonial. And finally, we'll share some tips to travel to treatment, especially for people living in rural areas. Before we begin, let me introduce myself. My name is Geoffrey Moll, and I am a Community Services Manager at the Leukemia and Lymphoma Society of Canada. I will be the moderator of this online event. We invite you to type your questions and comment in the Q&A box at the bottom of your screen throughout the presentation. An LLSC staff member will monitor the questions, and I will read some of them out loud at the end of the presentation. I would like to remind everyone that due to the large number of participants and limited time, we may not be able to answer all the questions. Please note that our guests cannot answer specific questions about a person's health, history, or status. Today's presentation will be recorded, therefore you can rewatch it again on our website. Next. As we come together from across Canada, we recognize that we are on lands cared for by many Indigenous nations. We honor the First Nations, Inuit, and Métis peoples whose deep connections to these lands enrich our community. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, belonging, and health equity guides how we work to support and uplift everyone affected by blood cancer. Next. Before I introduce the speakers, I want to share the important mission of our organization. Are you looking for specific programs or resources but not sure where to find them? We are here to help. You can connect with the community services lead in your region to receive personalized assistance and get connected to resources in your area. Reach out by calling toll-free 1-833-222-4884. Next. We know that having a diagnosis of blood cancer can be very overwhelming, but know that you are not alone. There is a blood cancer community that is here to support you every step of the way. As mentioned earlier, you can access one-on-one support to help you navigate the blood cancer experience. Next. The information and resources on our website are tailored and presented in multimedia formats to address the variety of needs and preferences of our community. This includes fact sheets and booklets like the ones you see on your screen, along with podcasts from our channel called The Blood Cancer Experience. Check out our resources to learn more about CAR-T therapy. Visit bloodcancers.ca to read, listen, and watch all these great resources. Next. This September 2025, the LLSC has started a brand new virtual support group dedicated to CAR-T. This group is meeting every month and is open to people preparing for, receiving, or recovering from CAR-T cell therapy and their caregivers. The discussions are professionally facilitated and focus on emotional support, shared experiences, and practical insights. The next meeting is scheduled to Tuesday, February 17th. Next. As I said earlier, this event is presented in partnership with Cell Therapy Transplant Canada. I'd like to invite Stephanie Meyer to tell us some more about this great organization.
Thanks so much, Jeffrey. Hi, everyone. I'm Stephanie Meyer. I'm the Executive Director of Cell Therapy Transplant Canada. We are a professional organization, not for profit, led by a board of directors. We're national in scope, and our members are from various different disciplines all across Canada. You can see on the right-hand side that we are made up of physicians, training members that are either fellows or basic lab trainees. We have a number of different allied health organization members, including from advanced practice professionals, laboratory, nursing, pharmacy, and also the quality managers. And a small percentage you see at the very bottom there, 3% are our patient, family, and caregiver members. The mission of CTTC is to be a community of excellence, leading national efforts to improve patient lives in hematopoietic cell transplantation and cell therapy. We do this through educational activities like our annual conference and our annual webinar series. We prioritize clinical care and research, and we advocate for patient access to therapies in Canada and worldwide. Our website address is there on the screen. You can visit at any time. And on the next slide, you'll see that there's 3 ways to be involved in CTTC as a patient, family member, or caregiver. You can just be a general website patron. There's resources available on our website at no cost to you. You could also register as a CTTC member if you'd like to be a little bit more involved. You receive periodic emails about once every 2 months indicating some things that might be of interest, upcoming events and information. And you get access to free webinars. The educational webinars I mentioned, you'll get free access to those. And also our website contains past conference presentations that you can access. And as a CTTC member, if you would like to be even more involved, you can join our advisory group who meets monthly, and they connect with each other and provide input to CTTC. And again, there's our website if you're interested in learning more. And back to you, Jeffrey.
Thank you, Stephanie. So it is now time to introduce our guest. So we have Dr. Hay. He's a hematologist and associate professor at the University of Calgary, who specializes in the development, translation, and biomanufacturing of adoptive cell therapies. He currently leads biomanufacturing efforts, clinical research, and a research laboratory focused on improving cellular immunotherapies at the Riedel Center for Cancer Immunotherapy. Dr. Hickey is a hematologist and clinical assistant professor at Memorial University of Newfoundland, who specializes in allogeneic stem cell transplantation. She currently leads the Newfoundland and Labrador Cellular Therapy and Transplant Program, where her clinical research focuses on improving outcomes of transplant patients in both the urban and rural settings. Christina Sitt is the manager of the Advocacy and Community Engagement team at the Leukemia and Lymphoma Society of Canada. Her team recently led a study about access and travel to treatment for people with blood cancer across Canada. And finally, Rod Delaney is the mayor of the small cities of Cupids, Newfoundland and Labrador, and cancer survivor. And Joanne Wells is Rod's care partner, as well as a health advocate and health policy collaborator. They will offer a testimonial. So we're going to start with Dr. Hay. Welcome, Dr. Hay.
Okay, great. Well, thank you very much for the introduction, and welcome everyone to join this webinar. If I could get the next slide, please. And next slide. So I've been asked to speak to just an outline of what CAR-T is and how we can access it here in Canada, and really who qualifies for it and what's currently available. As a lot of my co-presenters today will be discussing traveling for care, I will try to avoid discussing that, as you will get a lot of discussion about that from my other presenters. Next slide, please. So just to go over CAR T cells again, to remind everybody, I know people have various different levels of knowledge right now as to what CAR T cell therapy is, but it falls roughly within this pillar of cancer care called immunotherapy. If you put my animation on there, you can hone in. That's that the green column there, where really it's only been within the past roughly 35 years that there have been really developments in immunotherapy. Examples of other immunotherapies other than CAR T are the bispecific antibodies that have been developed, like, blinatumomab, glofitamab, epcoritamab, but even something such as rituximab, which, we consider quite standard therapy now for B cell cancers, such as diffuse large B cell lymphoma, mantle cell, or follicular lymphoma. Really, that has only been since around the 2000s. So you can see that although this has been this long history of cancer care, a lot of these major developments in immunotherapy have happened over the last, I would say, 25 years or less. Next slide, please. So what is a CAR T exactly? Well, first of all, what is a T cell? Well, a T cell is part of our normal immune system that is able to recognize abnormal cells in the body and get rid of them or kill them. This is often, virally infected cells, or it can be actually precancerous looking cells, or sometimes cancer itself cells that can be gotten rid of right away. But cancers are tricky and they can develop these mechanisms to evade killing by these T cells. For example, they can get rid of the thing on the tumor cell that the T cells usually use to recognize that they're abnormal, called a MHC or major histocompatibility complex. And so what we've done with CAR T cells is we've armed these T cells in such a way that they can now recognize the cancer again and kill it. So that's what these chimeric antigen receptors do that we put into these T cells so that we're able to kill off these cancer cells. Next slide, please. So in such a way, we put this new gene, this CAR, into the T cells, and so they are a genetically engineered living drug that we infuse into a patient. I would encourage you to look at some of the Leukemia Lymphoma Society podcasts or webinars that Jeffrey has already mentioned. Or for an example, look at this BMT 101 CTTC webinar that I did that actually breaks down, the basic steps of CAR T cell therapy that I've outlined here on this slide. But in brief, it involves, first of all, isolating the T cells from the patient, taking those T cells to a lab where they get modified to include that CAR in them. So this involves delivery of the gene in some way. So this is often done through a viral vector, which a viral vector, it's not like you're getting a virus. It's basically we're using the machinery of a virus to transfer the gene, but it's actually the virus doesn't replicate or cause any problems in the person. And then meanwhile, while these CAR T cells are being manufactured, and once they've been returned to the site, we need some sort of what we call immunosuppressive chemotherapy. This is often something called cyclophosphamide and fludarabine that is given to help kind of prepare the body to receive these cells. So it's kind of like creating room or space in your body so that it allows these CAR T cells to have all the nutrients and space they need to grow and expand. And so what you'll see after they've been infused into a patient is that they'll start at a certain level. And then once they see the things they're supposed to kill, they'll kill them off, but they also kind of create and mount an army that is able to go and kill all the rest of the cancer cells that they can see. And then once they've done the job of killing and they've reached kind of their peak of expansion, they can, slowly get rid of themselves and come down into a bit of either a persistent state or potentially go away entirely once they're no longer needed. Next slide, please. So I've talked a bit about already this chimeric antigen receptor. I just thought I would briefly hone in on the fact that there's actually a lot of different pieces to this chimeric antigen receptor. And the reason I bring this up is because you might hear about slight differences between different CARs. And some of it has to do with some of these differences in how they're designed. So, for example, this SCFE, this is the part that is targeting on the outside that is able to recognize the thing on the tumor cell that it's supposed to attack. So you can use various different forms of that protein that's hanging out outside of the CAR to target various different things on different cancer cells, or maybe they target the same thing but in a slightly different fashion. Um, there's this hinge or spacer region, so it depends upon how far this thing sticks outside of the T cell, and it causes it to change how it works potentially. There's these things that are actually help kind of make it stay in the cell surface to call this transmembrane domain, which can cause it to act differently. One of the big things you would hear about potentially is this thing called co-stimulation. So this is where, a T cell needs a couple different signals to say, okay, this is something to kill and this is something to act on. And so we use various different co-stimulatory domains depending upon the CAR to try to tell it what to do. And the main purpose of this slide is to show you that there's so much you can do to change a CAR T cell and how it works or how it functions by making small changes to all these various aspects of that CAR um, gene or that CAR protein that you've put into these cells. And so you might hear about, lots and lots of different trials that look at changing how what is on the CAR or how the CAR works. Most of the cars that are in use today are targeting something like CD19 or BCMA. I'll get into that a bit later. And most of them use one of two co-stimulatory domains, which is this CD28 or 41BB. I won't go into too much more detail than that, but just to say there's a lot of work being done. Next slide, please. So I mentioned already CD19 and BCMA. So that's that what it's targeting on the outside. So how do we determine what to use and how to target using a CAR? Well, we have to have basically two basic principles in mind. One, we want that target to be on all the cancer cells because we want to get rid of them, as obviously, and we don't want extra cancer cells sitting around. But it also has to be either absent on non-cancer cells, or you can actually tolerate not having those normal cells in your body. So an example I give is, if there's a great target against a lung cancer, for example, but it gets rid of the rest of your lungs, well, that doesn't quite work, does it? Like we need something that would preserve the rest of your lung cells, right? Because you can't live without your lungs. Um, What's interesting about B cell cancers and multiple myeloma, which is this plasma cell cancer, is that actually absence of having normal B cells or having plasma cells is it can actually be tolerated. So we're able to actually kind of broadly get rid of, in the case of CD19 CAR T cell therapy, B cells at the same time as we're getting rid of the lymphoma or the B cell leukemia because you can actually live without your B cells for a period of time. And the same thing with BCMA targeting for multiple myeloma. You can get rid of your plasma cells that make all your antibodies. You don't necessarily need them. Now, both of them are important arms of your immune system, and so one of the side effects might be that you have a longer term kind of immune suppressed state. If we have frequent infections, et cetera, we can often replace that the lack of having the antibodies, which is really what the B cell and plasma cell system does, by giving antibodies from normal people. So that's part of what makes absence of these normal cells being tolerated is that we can give you antibodies from other healthy people that have been pooled and help you deal with this side effect or of the targeting and getting rid of the cancer. Broadly speaking, work is being done on more targets, trying to design safer targets for a broader range of cancers. So not just blood cancers, but also solid tumors as well. Next slide, please. Um, and then I've talked a lot about that kind of and what I call the anatomy of the CAR itself. So that's the gene we put into it that does the targeting, et cetera, and causes that T cell to activate. But there's a lot of work being done also on the other sides of this, such as choosing which cell to put the CAR into. So we can look at, looking at these more what are called stem central memory T cells, or actually these allogeneic cells, allogeneic meaning from a healthy donor, so things like NK cells or double negative T cells that actually won't cause problems potentially if we put them into another person. So, or is there some way we can actually change the healthy cell T cells from a normal person so that they're tolerated to be in your body? The other things we look at is trying to find ways to target the tumor, like we speak often in solid tumors also too about this microenvironment. So this is kind of this surrounding immunosuppressive area that kind of turns off the T cells. It's not exactly the tumor itself, but all the stuff surrounding it. And so, looking at ways of armoring these cells so that they can actually attack better once they get into that microenvironment and don't get turned off. There's changes we can make to the actual manufacturing process. We can shorten the manufacturing process so that the cells are outside the body for less time, and so that we get them back into a patient sooner. We can target more than one target. And so that way, maybe get rid of more of the cancer or prevent it from escaping from the one target. And there's different ways in which I mentioned the viral vector of getting that gene in, but there's other ways that are in development, such as CRISPR technology, which are ways of getting genes into cells that are in development. And finally, there's been some work and evidence now on actually just making the CAR T cells in your body by injecting um, a molecules that will these are kind of nanoparticles basically that will go and find the T cells and actually put the CAR into them directly, so they don't require harvesting of the cells, etc. Now, all of this is a fast-growing field. There's a lot of development ongoing, but I just basically wanted to say that we're really still at the very early days of what we can do with cell therapies. Next page. So let's come down to the actual current situation. So what CAR T cells are currently available in Canada? Well, all currently commercial, like as in not on trial, CAR T cells in Canada target CD19. So they're for B cell lymphomas or leukemias. And they're all autologous, of that meaning from self, which means we have to collect the T cells from the patient, and there's an individual manufacturing run for each patient. Next slide, please. The next thing I wanted to touch on is how do CAR T cells get to what's called commercially available or funded in the province? Well, first of all, the drug companies have to submit to Health Canada to see if their drug can get what's called a notice of compliance or a notice of compliance with conditions, which basically allows them to market the drug in Canada. So that's regulated on a national level by Health Canada. What also occurs roughly at the same time or after that point in time is there's another body that does a funding recommendation to the various different provinces. And that's a body that used to be called CADTH, and it's now called CDA, or Canada's Drug Agency. And what this agency does is it looks at all the available evidence and says, based upon how much it costs, as well as the evidence of how well it works, do we recommend funding it or not funding it across the various different provinces? And they just provide a national recommendation. But then the provincial cancer agencies have to make funding decisions on a provincial basis. Now, there often is some negotiation that occurs on a national level, but at the end of the day, each province has to decide as to whether they sign on to that funding decision. And so, although we often talk about a national healthcare system in Canada, we really have a bit of a national scope when it comes to regulation of drugs, but the actual funding and availability is provincially led. And even on a provincial level, the operations and delivery of various different therapies, especially something like CAR T cell therapy, that's really dependent upon hospitals, it depends a bit upon each hospital's abilities and capacities to do this and the cancer care agencies involved. Next page. So just so everybody knows, kind of CAR T cell therapy became first available in the US in 2017 on a commercial level. And it was two FDA approved products, and none of them were available in Canada. Some centers in Canada had some limited trial experience, and some patients were funded to travel to the US, and the price tag was over $1 million per patient. Next slide, please. Now in 2025, we've made some significant improvements. We now have a large number of centers. Most provinces are included. I note that, Newfoundland, for example, we're going to be talking a bit about that later, is not does not currently have a CAR T-cell infusion center that I know of. And CAR T-cell therapy is still limited to some centers of excellence. And the price tag, it has come down to about $500,000 Canadian per product. So it's still quite high, but we've now treated across Canada around 1,000 patients or more. Next slide, please. These are the currently, approved CAR T-cell therapies that are available in Canada. Kymriah, Yescarta, Tecartus, and Breyanzi. They all target CD19 as I described. On the right-hand side, you see when they got their notice of compliance from Health Canada. And in the middle, you see various different approved indications. So which one you would get as a patient, or your family member would get as a patient would depend a bit upon, what does it fit one of the approved indications? And then some of them, so for example, Yescarta and Breyanzi, depends a bit upon where they have, the same indication, for example, listed, is whether or not it's funded and approved right now in that province. An example I can give of Breyanzi, although it got its notice of condition in 2022 for large cell lymphoma, we still don't have it available in quite a lot of provinces, but it's being rolled out this year, and it may be a successful thing to use instead of Yescarta, which has actually been the predominant one we use in most patients. Next slide, please. So I wanted to briefly talk about BCMA-directed CAR T-cell therapy for myeloma because I know this is something that a lot of my myeloma patient groups have been discussing right now. Interestingly, both Idacil and Cilta-cel, so Abecma and Carvykti, are approved by Health Canada. So they've been approved at that level to say that it's efficacious and the safety profile is okay, and they agree that it can be marketed in Canada. However, Abecma, because of its evidence, it wasn't sufficient. CDA thought to provide a recommendation to reimburse, so they came out with a review that said do not reimburse. Carvykti, when it went through CDA, they actually received a reimburse with conditions, but funding negotiations with the provincial cancer agencies has failed currently, and there is no funding decision yet. I understand from the company and the provinces that there might be some movement on this, but we are blind to kind of these funding negotiations that occur. So currently there is no CAR T-cell therapy for myeloma available in Canada unless it's on a clinical trial, which is something we hope to remedy in the future. Next slide, please. So how do I get CAR T? In brief, starts with a primary hematologist oncologist identifying that the cancer is approved. The primary hematologist refers you to the CAR T cell specialist at the CAR T center. That specialist determines that CAR T is indeed the best option, confirms that, and that you're fit enough to receive it. We need to collect the cells because these are all autologous products, as mentioned. Send those to the company that manufactures or the lab that manufactures, and then those get sent back, a few weeks later. And while you're waiting to get your cells back, the CAR T-cell specialist will often recommend some degree of bridging therapy to get the cancer under control until those cells come back. And then they're infused after that lymphodepleting chemotherapy is given. And as these CAR T-cells are associated with some specific toxicities, patients typically need to stay, close to the CAR T-cell center for the first 3 to 4 weeks after the CAR T-cell infusion. Next slide, please. I think that was it. So I'm going to hand over to Christina at this stage.
Thank you
Thank
so
you.
much. Thank you so much, Dr. Hay. And as Dr. Hay was saying from the presentation, you can see the opportunity that is offered to CAR-T, through CAR-T, the opportunity to have many more hugs, memories, and meaningful life moments. But the trick is, how do we get to CAR-T? And that travel to treatment really is a significant, it has a significant factor. As you can see from the quote from the next slide, like people say, children can't go to their, next slide, please. Children can't go to couldn't continue their extracurricular activities. People have to sell their cars. They have to turn their lives upside down. This family shared with us that it's totally ruined their family life. And so that's why we undertook this travel to treatment study. As you can see from the next slide, the methodology that we did with this for this study really centered around people with lived experience. We did undertake the study to measure this physical, psychosocial, and financial impact of traveling to treatment. So we went right to the community. We had a steering committee of 6 members and 4 with lived experience, including 1 social worker. We administered the study last year and finished in January of 2025. Our selection criteria were those with living with the blood cancer for 5 years, their caregivers, treated in an adult center, and travel to treatment was self-defined as travel to treatment outside of your home city. We were very, very fortunate to have 454 respondents to this study. So what did it show? Distance and time cost. Really, there's a theme. The theme was too much, too long, too much time. And as you can see, the travel distance, more than, next slide, please. If you look at over 100 kilometers, more than 50% had to travel more than 100 kilometers to get to treatment, and more than 15% had to travel more than 500 kilometers away from home to the treatment. Too long, too far. Next slide will tell you that the time that they needed to go to treatment, more than 40% traveled for 3 hours or more to get to treatment. And on the next slide, you'll see that it takes years of treatment. So more than 50% had to travel 2 years or more to get to treatment. Now that really, as you can see from the next set of slides, we'll talk to you a little bit about the financial impact. There's real people impact and real choices that have to be made. And when you think about it, what are the financial, the cost of traveling to treatment? What is that? What is that financial constraint? And you'll see on the next slide that, yes, people had to make a change in their life savings. Yes, people missed mortgage payments. But I want to draw your attention to the last point, 12.6%. In our country of Canada, 12.6% of the respondents turned to crowdsourcing platforms, GoFundMe, in order to be able to afford that treatment. Even if they've tried the rest of it, it still wasn't enough. Next slide. And it's not just that this one time. We're putting people, really handicapping people in their ability to be financially secure. More than 50%. 48.8% had more than a 10% reduction in income when it came to travel to treatment. And you can see up from the next slide that this has real people impact. People couldn't pay the rent in full. The cost of parking was outrageous. We're asking people to make choices. Once they're able to pay the rent in full, do they eat? And you'll see from the next, as we continue on in this presentation, that it's not just this one point in time. It has real ripple effects. 23.9% put their career on hold or had to refuse promotions. So this isn't just this one point. It has impact for the rest of their career and the rest of their earning potential. So as this family shared on the next slide, that it wasn't just the primary caregiver. It wasn't just the person living with blood cancer. It's a family affair. Their daughters had to take time off of work without pay to visit and help care for their father. It has ripple effects throughout the whole entire family. And unfortunately, as you'll see from the next set of slides, that the idea of travel to treatment really impacts the treatment decisions. We'll see from the next slide that you'll see delay, delay, delay. And that was the theme. You know, about 1 in 5 reported a delay in diagnosis because of the barrier. About 1 in 5 reported the delay in treatment because of the barrier, and so forth. The same theme resonates through the rest of the respondents. And, you know, we all know early treatment is a key success factor when it comes to cancer. Next slide, please. And, you know, why was there this delay? It's because it does have a real human impact. This family really shared with us, even though they had good family support, it took a dozen people working together to put the needs of the business, the family, the animals, getting them to the airport, helping them to the on the farm. And then the next quote I had to include in here because really, we're putting people in desperate situations. I don't know, and if anybody is able to, and you can share with me in the chat if you would like, but I can't afford a private plane to go into a biopsy appointment or any medical appointment. But unfortunately, this one was. But we're putting people in impossible situations. And does this have impact on family? Of course it does. You know, if you look on the next slide, you'll see that a significant amount of people had to live apart from their family. 48.6% had to live apart from their immediate family. And you'll see from the next slide that it wasn't just 1 month, 2 months. More than 50% had to live more than 3 months apart from their family when it came to treatment. The next slide will show you that it does have real human impact. It's just time you'll never get back. I feel I'm with the grandmother when she says this. It's an extremely rough, sad, unfair, difficult end of life for their daughter to be apart from that newborn granddaughter. Next slide, please. You know, family impact, 55% having negative impact on children that are inside the family as well. Next slide. Strain on marriage was another theme that was also shared. And then the next slide, please. I really want to bring us and ground us in this reality. Sacrifices are made by families every day due to travel to treatment. It is not just not going to the Tim Hortons. It's not just movies or missing important events, but 34.9%, draw your attention to the orange, tell us that they're cutting back on household expenses. These are heat. People are telling us, I don't remember the last time I ate beef. I go to the grocery store and I pick out the least expensive, the cheapest food I can find. And, you know, I dial back on the heat. And we all know that nutrition, comfort of living, these play such an important part of your recovery. So we're really handicapping the ability of the treatments, these innovative treatments that we know can work. And then we're handicapping their ability to work, and we're handicapping the community's ability to benefit from them. Next slide, please. You know, there is a mental health burden too, and I'm using this one to set up the next section. And it's you know, it's exhausting, not just for those that are living with the condition, it's exhausting for the family as well. It's a physical as well as an emotional toll. Next slide, please. And go forward, please. You know, the side effects of traveling with blood cancer, they talked to us about the fatigue that's worsened by travel, 64.5%. They talked about how nausea was worsened by travel. And many talked to us, you know what, don't just think about the getting to treatment, we have to get home too. Keep going. We just had lunch, but I always find going to a gas station washroom icky. And, you know, the indignity that we're putting our community through when they can't even find that washroom. Go ahead. And many commented on that idea of being a burden. So go ahead, please. You know, when people give them a gift, many do find that gift hard to accept. So what can we do about it? Go forward 3 slides, please. Oh, keep going. When our community has to travel, some of them just, they reminded us that not everybody has a companion to travel with. So if I may have the next, go forward 2 slides. What can we do about it? Really, it is a 360 approach. We really do need to wrap that hug around the community. Keep going. The first recommendation, really, we do need to redefine support. We need to have community support systems with multiple entry points, and really those so that we can connect the community to as much support as possible. Next. We really need to recognize the realities of access and inequality. Dr. Hay talked about our Canadian system and the process. The system always talks about equity, but we've never defined equity. So we need to have within this system, within this system of evaluation for equity to mean something. And that brings me to my third point. Next slide. We really need to include in our HTA submissions a Made in Canada and define a solution and definition to equity so that we can assign points to it, so that it can count for something. And we need to do that by gathering data and speaking with one voice. So this travel to treatment study with blood cancer was just the phase 1. We are embarking on a phase 2 where it's all cancer, so we can speak with even louder voice. And then we're adding a pediatric focus study to this in terms of travel to treatment. And that allows us to start the call for change. So I ask all the clinicians that are in the audience today, when we help us, when we have this opportunity, comment on that idea of travel to treatment and join us when we ask for input. And when I hope to see some of you in the CDA symposium, where we'll talk a little bit more about this and start that call for equity to mean something. So I hope I gave you just a glimpse. Next slide, please. Because this is such an important part of the treatment experience. And imagine that you are a mom, you're about to be a grandfather, you're both working, and your husband is also the mayor of a small town in Newfoundland called Cupids. But imagine having blood cancer and having to leave all of that behind, your grandchildren, and what do you do about your dogs when you have to go to Ottawa for treatment? And so I'm going to turn it over to Rod and Joanne to share that experience with you.
Thank you very much, Christina. Excellent segue into our story. So I'm going to tell you a little bit about our journey from my perspective. So we live in a small town, Cupids, Newfoundland, and it's approximately 700 people, and we're about 100 kilometers from St. John's, the capital of Newfoundland. Our story would start in 2012, and it's the initial diagnosis for myself, which was follicular non-Hodgkin's. About that time, I was experiencing a lump in my armpit, decided to get some treatment to get it looked at. We'd done our various tests, etc., and then the diagnosis came. But what was surprising at the time was that the diagnosis meant a treatment of no treatment. We were going to monitor it. It was nothing looked very threatening or sinister at that time. Would suggest that that lasted probably a couple of months. We went into a series for a very long period of time of different types of chemotherapies. We would do one cycle of chemotherapy, followed by an extended period of wait and see and monitoring, see how we were doing. Then we would go into another period of chemotherapy again because the tumors would return. Over time, the periods between chemotherapy and the return of the tumors was coming shorter and shorter and shorter. So this was going over a period of several years. And we'll take this forward to about 2019 then, when we came to the conclusion that, along with the medical team, of course, that the chemotherapies were not as effective as we'd hoped they would be. So what was brought to the table then was a suggestion to consider a stem cell transplant. So in keeping with the theme of what Krista articulated very clearly, travel was involved. We had to take a period of time off our lives. We were told in the neighborhood of up to 3 months to go to Halifax, cut short our lives, take everything with us, stop work, etc., as I received my stem cell transplant and then had to wait and see how that would take, how I would heal, how I would get better before we could even consider returning home. Clearly, that meant we weren't working. That meant it was only myself and Joanne, our dogs, and whatever pieces of life we could fit in the back of a Volkswagen Tiguan as we drove to Halifax from Newfoundland. So that would have been around 2020. And we remember that specifically because we were doing our assessment in March of 2020, came home, and then guess what? COVID. They shut down the country. That delayed our treatment options up until September. But of course, we did receive the CAR T transplant in September of 2020, and then this 3 month period of wait and see how the healing and how the transplant would take what's going to happen. We were able to come home then, I think, towards the end of October. And that would have been 2020 again, of course. And for a period of about a year and a half, we were celebrating, we were thriving, everything was great, impact health-wise, etc. It was great until I felt a lump come back in my groin. So naturally, we went to the doctor right away, early diagnosis being key here. And regrettably, we found that the cancer had returned and the stem cell transplant didn't take. This was in late 2021, 2022. It was late. So then we started another round of chemotherapy, of course. That ended pretty quickly because it was the chemotherapy.
I don't mean to interrupt, but this was my part of the the cancer journey, was remembering this stuff.
Yeah.
And the stem cell transplant, I don't know if what that didn't take, but with Rod, his cancer transformed, which is how we became a candidate for the CAR T. Because Rod's, I had to write this down because I don't remember everything all the time, but Rod's cancer had transformed to diffuse large B cell, and it was a very aggressive form of cancer. And talking to our doctor, who was amazing. I mean, we think of him as part of our family now, more than just Rod's doctor, even though he's not in our life very much anymore, I'm happy to say. There weren't any more chemo options left for Rod. So, I'll let you continue on. And that's then when we were presented with the CAR T being a potential option for us.
Yeah, so it was acknowledged then that the contemporary treatments of chemotherapy, et cetera, were not going to be viable going forward. So as Joanne said, it was CAR T was discussed and put on the table for our considerations, and perhaps we were candidates to receive that treatment. And fortunately for us, we were able to avail of that. We went to Ottawa then of June 2023 for the evaluation, and not so much for the evaluation, rather, I misspoke, for the apheresis, I believe it's called, whereby the cells are harvested to send away for the CAR T change. And we were brought back in July of 2023, and I received those CAR T cells, the immunotherapy, of course. And I got to say that it was probably the best things that could have ever happened to us at that time, simply because I'm very well now. I've had a successful immunotherapy. And it's important to say that my health has improved that much that is probably the best I've felt until about 2012. But now the important context here that needs to be part of this webinar is everything that was involved to get us to that point. We and everybody should have the opportunity to remain well while you're trying to get well. But for our experience, to have to pack up our lives like we did in Halifax and go to over 2,600 kilometers away to receive that treatment was so impactful mentally. We're living in an apartment, literally, like a hotel. 2 dogs, you, me, and literally nobody else. So the supports there were very limited. And from my perspective, at that time, I was not doing the heavy lifting. So aside from being trying to get well, experiencing various side effects that were related to it, and Joanne will speak to that, I'm sure. It was all that was on my mind the whole time that we were up there is how are we going to cope when we return back home? For us, it was about the finances. For me specifically, it was about the finances. Joanne was very focused on my well-being and my health. But I couldn't stop thinking about why did we have to come this far? Why couldn't we receive this treatment locally in the area? We're only 100 kilometers from St. John's, a city that probably supports a population pushing 200,000 people. So it is a modern city in that sense. But all our life savings were now exhausted. I myself, I'm a hospitality professional, so I have a good living. I have that opportunity. But for about, I would say, 8 years prior to up until that time that I received CAR-T, I probably was able to work maybe 20-25% of the time anyone would rightfully expect to work. And that takes a toll on your finances. We put our money away, of course, in savings, RSPs, retirement, etc. But I can say to you now, and I'm not ashamed to say it, my health being the number one important thing here, we don't have that anymore. So now the retirement that we looked at ourselves from 55 to 60 years old now has me looking at about 70 to 75. And for somebody that, you pay your taxes, you check off all the boxes that you're supposed to take as you get older so that you can live comfortably in retirement, it's all gone. It's all exhausted. And why do we have to go down that road when we live so nearby such a major metropolis of a city, when that care, as I understand it, could be brought to our local area? We wouldn't experience the mental challenges. We wouldn't have experienced the financial challenges. And secondly, we would have had supports that would have helped us remain well while we're trying to get well. Uh, Again, it's my perspective, the finances, etc., and the impact on it. But as I got better, as my cognitive senses returned to a place where I was thinking much more clearly, I wondered how my wife, who had to go with me, besides the obvious, being my wife, of course, but had to be my partner, my caregiver, had no one to support her. So there's so many variables at play here that made this experience, as rewarding as it was at the end, so unnecessarily challenging to get there.
I mean, I got to be honest with you, when I was listening to Christina speak, well, it was all fascinating. But when I got emotional, and through this journey, I've kind of thought I didn't have many more tears to cry, and everything is so good for myself and Rod right now that, I don't have anything really to cry about. But I really got emotional listening to Christina identify so many areas that affected our life, and we try not to think about it because, being positive was, I think, part of what got us through all of this since 2012. But, the reality of it is, I mean, my career completely changed. We had to make a choice because not only is it during the treatment time, but with the type treatments that Rod had received, his immune system, like with the stem cell transplant, especially, his immune system was pretty much nothing when we brought him home. And so, we had to isolate ourselves, not just from, strangers, but from everybody to ensure
before COVID.
Yeah, well, I mean, it was actually great, kind of, because COVID sort of made everybody like us. But, we had to start everything again. And then just as you start thinking, okay, now we're back on track, Rod just got healthy enough to start going back to work. and me deciding, okay, what career am I going to start doing now? So I tried starting a small business, and then boom, the cancer comes back again. We have to go to Ottawa this time. So, by this time, Rod had only been working in his job, for a little over a year, and he's very good at what he does, and every employer loves him. But, there wasn't that longevity there of, oh, go ahead for a year, Rod, and deal with your cancer, and we'll hold your job for you. That wasn't the case anymore. I had to close down my business, and then we had to, track everything up, the same Tiguan, because, we can't afford to get a new Tiguan. But that same trusty car brought us up to Ottawa. I packed up our two dogs. Rod had to fly up at that point in time because of his health. Um, it's just so impactful. It's impactful when you get there and you don't have any friends to call. I mean, I was trying to be Rod's support, but when I would get home at the evening, at the end of the day, before he actually came home, who was I offloading to? Just for that kind of confident boost, or you'll get through this, Joanne, or you'll be fine. And then a lot of the times too, I don't think you even know what kind of support you need when you're in it, because your head is so full of, like, I know from the CAR T treatment, it is very the way it was when we received it anyway. It was once he was I think he was hospitalized for about a week, maybe pushing two, and then he came back to the accommodation with me, and then I had to monitor everything for him. And that comes with another level of stress. And I just think, as I think about the things that helped me in between the over decade that we were experiencing the cancer, I remember at one point in time, I think it was between the stem cell transplant and the CAR T, I actually went and spoke to I think it was a life coach. She was a social worker, but it was somebody that I actually had to go find on my own. And I did. And it got me through, I think, the CAR T. It gave me the strength I needed. So I think it's important, if you're taking people out of their support group, their support area, that it's replaced with some type of a support. Now, it's really exciting to hear about this lymphoma support group. And so much so that I think I should talk to Christine afterwards to join it, because I definitely would love to be there for other caretakers that are going through this, especially ones that have to travel such a long distance.
Oh, Doctor.
Okay. And I guess on that quick exit, let's go over to Dr. Hickey.
Thank you so much. Wow, it's great to hear your story, Rod and Joanne. And I heard about it through the periphery of being here in St. John's. And so I'm hoping that I can share some insight on our experience here in Newfoundland. But really, that's kind of a testament of our patients and what it can be like. And that's coming from a very supportive family. So I'm going to start and talk a little bit about CAR T cell therapy and whether or not this can go the distance. I was asked to talk really on the rural component, and I will definitely touch on that. But ultimately, kind of as described, I live in St. John's. I don't consider this a rural area, but if I needed CAR T therapy, I would need to travel for it as well. So really, this is for a province of both urban and rural settings where we need to travel for our therapy. And there's certainly some issues that can go along with that. Next slide, please. So I'm going to start with a couple of cases, basically demonstrating some of the referrals we get for CAR T therapy. And really, I just want to highlight some of the challenges that we have, but also some of the successes that we've had so far. So the first case is a 65-year-old gentleman who was diagnosed with large cell lymphoma, had his standard R-CHOP. Unfortunately, he had progressive disease on his post-treatment scan. He went on to have more therapy with RGDP, then showed again progressive disease. And so at that time, the plan was that he was going to need a more permanent therapy. He was getting some temporizing radiation treatment with plans to go to CAR T therapy. At that time, the patient did not have a support person, unlike Rod with Joanne. And he also had a lot of financial concerns. And so he ultimately declined CAR T therapy and proceeded with palliative treatment in the form of Pola-BR. He ultimately passed away 6 months within the diagnosis. And so as I was reviewing this chart, this was from the primary hematologist. It said, we discussed again the possibility of going to Ottawa for consideration of CAR T cell therapy, but they felt it was unlikely his disease would remain in remission long enough to get him there, and the CAR Ts manufactured, which is quite possible. But regardless, there are financial and particularly personal constraints of him going to Ottawa, since he would require someone to be with him during as a caregiver, and he does not have anyone to act in this capacity, which is not an uncommon thing that we see. All right, and I'll get next slide, please. So the next case again is a 75-year-old woman from the Avalon Peninsula. So she is within an hour of St. John's. She had a little bit of a longer history with her lymphoma, was diagnosed in 97. She was treated and had an autologous stem cell transplant for her refractory disease. She went on to have follicular lymphoma in the background, which relapsed multiple times, and then ultimately, many years later, relapsed with the large cell component in April of last year. She was referred to CAR T cell therapy at that time, and she had her leukapheresis done in July. And when she went up and had her T cells collected, she wasn't feeling well after they were collected. She was confused. She was supposed to be returning back to Newfoundland, but ended up getting admitted to the Ottawa hospital. She was found to have pneumonia, hyponatremia. She went into cardiac arrest and died in the ICU just shortly after her T cells were collected. And I'll go to the next case. So the next case is a 35-year-old gentleman who had advanced stage large cell lymphoma, treated with 6 cycles of R-CHOP. His post-treatment PET, however, did show an excellent metabolic response, but he had a very small 10-millimeter lesion. And it was felt that this actually probably wasn't related to his lymphoma. He had flu-like symptoms at the time, but I presented him at our tumor board rounds and we said, let's do a short-term PET scan just to make sure it was nothing. That lesion in the short-term PET actually went completely away, but they incidentally did pick up on progressive disease. And so at that time, a very prompt referral was made to CAR T cell therapy. His funding was approved within a year, and he went for leukapheresis within 3 weeks, traveled to CAR T cell therapy 4 weeks after his leukapheresis, and ultimately he's done quite well. Next slide, please. So I just wanted to touch on the referral process for CAR T cell therapy, and this is for anybody, whether you're living rural, urban. You're going to get referred to a CAR T center, and sometimes that is local, sometimes that is going to be much further away. There is an eligible, the patients need to be determined to be eligible, and they need to be approved through their government funding. Patients will then go for their leukapheresis. They may or may not need holding therapy, and that the holding therapy may or may not come before the leukapheresis, depending. Then they go for the CAR T cell infusion and then the post-infusion monitoring. And so as Dr. Hay has gone through, CAR T right now is offered in the relapse and refractory setting, and it's quite time sensitive. Typically at this point, we're dealing with more aggressive type disease. And so this process needs to move fairly quickly to get the best outcomes. And so a couple of terms that have been helpful for us to look at these timelines. One is the brain to vein time. So that's the time that the clinician sees the patient and says, yes, they need to go for CAR T, to the point that a needle is put in and those T cells are being collected. And then the next time point is the vein to vein time. So that's from the point that those T cells have been collected and then they are being reinfused after they've been manufactured. So the brain to vein time in the best case scenario is 2 to 4 weeks, but really studies and real life data is showing that this is taking upwards to 4 to 8 plus weeks. And that really depends. Oh, just go back. Thank you. It could depend on a number of factors, which I'll get into now in a second. And then from the vein to vein time, that is a little bit less in the clinician's hand. So this is typically a 2 to 4 week period, and that has a lot to do with the manufacturing of the product. Right, next slide. So the brain to vein time really reflects kind of the promptness of being able to get referred to that CAR T cell therapy center, getting that eligible workup, making sure that the disease is okay to proceed on with going for the therapy, getting all your funding in place, getting your apheresis time scheduled. Whereas the vein to vein time period is really more reflective of getting the CAR T cells manufactured, getting them shipped back to the treatment center, scheduling your chemo and admission. And so in terms of delays in either, it can increase the risk of bridging therapy or increase the risk of disease progression. But from a brain to vein perspective, we as clinicians have probably a little bit more control in getting that time frame maximized, whereas vein to vein is a little bit more out of our hands. Next. And next, yeah. So I want to discuss a little bit of the referral process for patients here in Newfoundland and Labrador. So in terms of the referral, they're first sent to we have a Newfoundland Labrador transplant coordinator. She deals with both of our allogeneic stem cell transplants, which also go to Ottawa, as well as our CAR T cells. And then at the same time, we put in a funding request to the Newfoundland government, which takes anywhere from 1 to 2 days. Is actually pretty prompt. Then once the referring hematologist has seen them, we sent up a consult to our Ottawa team, and they will meet with the patient typically within a week or so. So again, it's quite prompt. Kind of the combination of that meeting with Ottawa as well as the government funding, we will get an approval. The goal then is to get them to leukapheresis as soon as possible. Usually from the time they meet Ottawa on their original Zoom meeting to getting up there, if there's no delays, is 2 to 3 weeks. They will spend 1 week in Ottawa for the actual procedure. Then they will come back home. Ideally, we try to reserve holding therapy until after this if it's needed, just because it can impact the quality of the T cells. So if they come back this time point of holding therapy, I've had patients who haven't required anything. I've had patients who were on their way to the airport and we've had to stop them because their disease has progressed and we've had to hold them back for treatment. So it's really, that time frame can be very variable. In terms of the CAR T cells, getting them themselves, patients, once they've been home, will then travel back to Ottawa. So that's their second trip there. And this time they're there for 1 to 2 months, which varies on how well that they're doing and if there's any major complications from the treatment itself. If once they're stable to come home, if they're not living from St. John's or originally from St. John's, we do request that they stay in the city for at least 1 to 2 weeks so that we can do their monitoring. Some patients still require transfusions, and depending on where they live, we may not have access to platelets or blood on a regular basis, and so they may need to stay even longer. Next slide, please. So I wanted to just introduce you guys all to my beautiful province, which was just spoken about. But for those of you who are not familiar, this is Newfoundland and Labrador, and as you can tell, it's quite large. I demonstrated some pictures of our beautiful downtown St. John's, of the west coast on the Gros Morne, for people who've probably been here recognize that, and then a couple of pictures I've included from that I've taken hiking on the East Coast Trail. So it's a very beautiful place to live. But what we access in kind of its rugged beauty, we lack in the geographical conveniences. And so as you can see down here in the very bottom corner, where St. John's is located, that is where 12 of our 12 hematologists reside. There is no hematologist outside of St. John's, Newfoundland. So we cover this entire province, both Newfoundland and Labrador, from this little corner here. The total population is just over 500,000, and St. John's holds about 186,000 of that. So you can imagine there's still quite a large number of patients that we are covering that are quite far away. And to put that into perspective, our patients in Labrador are over 2,000 kilometers away. So for us to see them in person, it's either a 24-hour drive, which no one ever does, or a 2-hour flight. And then kind of on the tipping point of Newfoundland to St. Anthony, that's about an 11-hour drive. And then our second largest city is in Corner Brook, which is about a 7-hour drive. So it's, quite a feat to try to access care to all of these patients from our single location. Next slide. So I just wanted to review the referrals for our patients, just to give you guys an idea of what that looks like. So over the last 5 years, we've had 52 referrals. And if you go down to the right side there, of those 52 referrals for CAR T therapy, 17 people did not go. The reasons behind that were for financial, lack of support partner. They were not considered a candidate. 8 patients relapsed or died, weren't able to get to the CAR T therapy. 1 patient refused for reasons that weren't stated, and 1 actually went into a remission that didn't require further therapy. In terms of the patients that did receive their CAR T cells, 17 are still alive and disease-free. 15 have subsequently died. 3 have relapsed but are still alive, and 2 currently are in Ottawa. And these were the numbers when I did this presentation. As you can see, kind of down in the corner, we did have a couple other cellular therapies in really early days, Boston and Quebec, but now our primary center is Ottawa and has been since many years, since at least 2021. I think it's important to note that this does not capture patients who qualified for CAR T therapy but refused. They just did not want to be even considered for referral. And when I was coming up with this talk, I did send out an email to the hematologist here and just asked had anyone had experience. And there's quite a bit of information, quite a bit of response back saying that that was the case. A lot of people who just did not want to go and were unable to go. Next slide. So here is a picture showing all of the referrals and where the patients were located. So not surprisingly, the majority are in St. John's, but still there's quite a number of people dispersing all over the province as far as Labrador. So we did have quite a variety of where people are located. Next. So I just want to talk about some of the patient challenges and really, the best, this is going to be best from our patients who have spoken earlier. But first and foremost is the financial strain. And so when I go in and talk to someone about CAR T cell therapy, and I will talk to them about what that is and what their side effects are and go through an hour-long talk about it, the first and foremost question I get is, how much is this going to cost? What's the finances regarded to it? It's always the first thing on the mind. And this is keeping in mind someone who's just spent a year getting treatment, going into treatment with their pre-chemotherapy, and then having another 6 months plus of therapy. Support person, definitely not always available. If they are available, this is typically the person who's their primary income at that time, who now also has to take time off. So that's also another major challenge for our patients. Time away from family and time away from home really cannot be understated. I have patients who have young children. I have patients, as spoken about earlier, who have pets, who have taken their pets with them. The comforts of home, the comforts of routine. I've had patients who've never flown, who don't even like to come to St. John's because they prefer to be in their smaller communities. So that in and of itself has been a deterrent for several patients. Next slide, please. So how can we improve this? In terms of the financial strain, we do have a social assistance worker who's involved very early on. Our patients are part of the Kite Connect patient support program, who provide the financial funding for them to get their CAR T treatment in Ottawa. We use satellite sites if possible to give our treatments, which are smaller centers across the province. And we try to be available to do any disability forms and things like that for our patients. In terms of support persons, if they're unable to get someone and the patient is the right fit, we will sometimes just admit them for their procedure without the ability of a support person. Time away from family, really there's only so much that we can do, but we do try to provide the emotional support and get social work involved as well. And similar for time away from home, just giving them information about where they're going. Some people don't know Ottawa, have never been there. Next. So this is just our Kite Connect support program, which just explains that they cover our travel accommodations and any travel once the patient is there. Next. So for physicians, this is also a huge challenge. It's very difficult to assess disease status when someone is living 12 hours away. We rely heavily on our virtual appointments. We rely heavily on our satellite sites for seeing patients, but it's not the same as the hematologist seeing them in person. There's usually rapid change in their disease, and a lot of time there's a delay before we even get to see them when these symptoms are returning. In terms of disease prognosis, when I'm seeing a patient to tell them that now their disease is relapsed or refractory, that's one big blow. And then I have to talk to them next about going and traveling out of province. So it's a long appointment. We're then talking about the need for potential bridge therapy. And so these are big, heavy conversations to be having with a patient and often requires extended time. And then from a pre-CAR T cell workup, we then need to get rapid PET scans, echoes, PFTs done, and trying to get this on a peripheral site is not always the easiest, and we may need to get them to travel to St. John's, which again is adding on to all the stress that they're undertaking. Next. So how can we improve this? In terms of assessing the disease, is there a role for doing PET scans for our patients without necessary clinical indications? Maybe. We see that with one of the cases I presented. It was an incidental finding of progressive disease, and he ended up getting caught early. With regards to disease prognosis, we really just need to book these appointments longer and oftentimes in person. And then for the pre-CAR T cell workup, we sometimes do need to admit patients to expedite things. Next. So just a quick moment on practical tips for travel. So financial, as I mentioned, we do get our social assistance workers involved. We confirm what is covered by the provincial funding, refundable flights if you don't have someone who's covering that in case there's delays. From a health perspective, we try to get direct flights to minimize infection risk, bring masks. They have to take all their medications, thermometers, hand sanitizers, have all their contact information available, have peer support programs for any emotional support. And then practical considerations, we just try to give them, like I said, the information on the groceries, pharmacies, restaurants that are available, and to take the comforts of home if possible. And next. And so just for getting back to the time purposes, in terms of the cases, I just wanted to say things that we could potentially improve. So for the first case, this patient was not able to go because of financial and support reasons. Just click, yep. And so basically now we have the Kite Connect program, which helps with the finances. And if the patient is deemed suitable, we would admit them. Next. And for this second case, really, now we have CAR T in an earlier setting. This was a multiply relapse setting, but now in the earlier setting, this may mitigate some of that risk. And then for the unexpected death out of province, really, I don't know if there's a solution for that. I think this is just one of the challenges we have in this situation. And next. And finally, for this patient, I just wanted to highlight that this was one of the best case scenarios. We ended up catching progressive disease early. We were able to get the patient up and get their CAR T cells within really 4 to 6 weeks, and he's done amazingly. And finally, last slide. So just for my final thoughts, as echoed above all the previous talks, is that this is a life-saving intervention and really needs to be accessible to everybody. The barriers for our patients tend to be financial, bar none is number one, followed by caregiver availability and then disease progression occurring. You need a team of people to make this successful. And finally, in St. John's, we're hoping to get a CAR T cell site here in the next couple of years. The proposals put in, and we're hoping that this will really minimize the travel burden for our patients. Thank you.
Thank you so much, Dr. Hay, Christina, Rod, Joanne, and Dr. Hickey for sharing your expertise and insight with all of us. It is now time for Q&A period. As mentioned in the introduction, please type your questions in the Q&A box at the bottom of your screen, and I will read them out loud. We already have a lot of questions. Since there are many of you participating and time is very limited, we may not be able to answer all the questions. If we can't answer your question, we'll contact you personally in the next weeks. Please also note that our generous guests cannot answer specific questions about an individual's health or questions unrelated to the topic of the presentation. So we received questions in advance. We received a lot of questions during the presentation. I'm going to read some of them to you. I guess this question is more for Dr. Hay and Dr. Hickey, but what is the recovery from CAR T like? What does it look like? What is the survival rate also now for one person who has CAR T?
Sure, I can handle that. Uh, Really, the recovery depends a lot on the individual and whether or not they have some of those acute toxicities from CAR T cell therapy called cytokine release syndrome and neurologic toxicity. Those tend to resolve within the first couple of weeks or so after CAR T cells. But I would say the majority of my patients, by the time they're a month out, they have started to recover quite a bit. But they're definitely not back to their normal kind of activity level, etc. And I would say on average, it takes people about 3 to 6 months before they're feeling like kind of totally up back to normal. That being said, I have a patient I just treated recently who's like already fully back up and recovered and just still within that 1 month window. So it's very dependent upon how sick you are going into CAR T cell therapy, usually because of the lymphoma, but also other medical problems you might have as well. That depends a lot on how your recovery looks. Your immune system takes a lot longer to recover from CAR T cell therapy, sometimes years for some patients. So that part can be a bit more complicated in terms of the recovery. Finally, the second part of that question regarding the actual outcomes, I would say that depends a lot upon whether it's used in the third or second line setting or which disease we're talking about, ALL versus diffuse large B-cell lymphoma. So I don't want to make like a generalization there about what the long-term outcomes are like. I think that requires a bit more of a specific discussion regarding what particular lymphoma and what particular line of therapy you're interested in.
Okay, thank you. So also just to clarify, so people get CAR T cells, and at some point these cells die. I imagine they're not staying in your immune system forever, but do they replicate? Is your immune system equipped to recreate these cells too?
So, as I mentioned in my talk, they're a living drug. Basically, it's a cell and these cells have the capability to make more of themselves, and that's one of the things they do when they see their target that they're trying to get rid of. Is yes, they kill it, but it also sends a signal to them saying we need more of us, and so they replicate and they make more. They kind of mount an army. So they have that ability to do that. Um, as to whether or not they stay in your body or not, the term we like to use is persist. Um, it varies a lot. Depends a bit on the disease, on the CAR, and there's certain diseases of where this persistence um, is probably more important. For example, in B-cell acute lymphoblastic leukemia, it's probably more important that these cells persist than in something like diffuse large B-cell lymphoma or mantle cell lymphoma. There have been studies done, one that was published a few years ago now, that showed that these cells can hang around for more than 10 years in some patients. So there are some patients who have long-term persistence, and there's some patients who after the first month it's gone and we can't find it anywhere. And we still don't fully understand everything that goes into making these last longer or not in the body, and also whether they need to be there longer or not. That is an active area of research and development.
Thank you. I have a question about side effects. So I'm going first to ask Rod and Joanne if they can share a little about what the side effects look like. Just quickly, if you had to identify the main side effect that had the biggest impact on your life.
So, side effects. Where do we start?
Well, I will start quickly by saying the biggest side effect I think that impacted me personally was I laugh at this now because it's easy to laugh at it now after the fact. But part of the CAR T treatment for Rod was to take, and I don't remember the name of the drug, but it was some type of an antipsychotic they gave him post receiving the CAR T, but it kind of made him psychotic. So that I was trying to make a joke out of that, but it doesn't sound very funny, does it? But he really did. He kind of like I didn't recognize the man that he was anymore. And it was for a period of time. I mean, I took him back to the accommodations, and I mean, he was tired and a lot of the typical things, but then he did change. He had changed to the point where, I did have to bring him back to the hospital. Like I did call the emergency number that they gave just to tell them what was going on. And then it was recommended that I bring him back. And he was probably in there for about a week after that, maybe. But now let him speak to the.
Yeah, so we were going down a period where they assured us that there was going to be some side effects, but I wasn't presenting any side effects, and I was bragging about how I'm not going to present. Lo and behold, after about maybe a week at least, I presented, and boy, did I present. So I got to admit it, I had the worst migraine I think I've ever felt in my life. For somebody who's never had a migraine in his life, it probably persisted for about 2 full days, and it was intense. Uh, I had rigors, like the rigors. I can't describe them, how profound they were, how debilitating they were. Cognitively, I wasn't with it. Let's just call it in very clear language. I knew who was in the room with me at any given time, but the perception of daytime, meal times, daylight, etc., was a challenge for me.
I'll say this because it'll probably help understand too. The psychiatrist that came in to speak with Rod when we went through that period, I loved how she had said this too. Rod's personality had gotten a little more theatrical. So that was, and yeah, let's just leave it at that. And all things that can come with somebody's personality kind of being magnified a little bit.
Yeah, I'm a pretty calm guy. I don't know where that came from. Yeah, so psychologically and the physical pieces, they're probably limited to the physical pieces that I mentioned. I never had any nausea. I never had diarrhea or anything to that effect. They were quite physical, headache, rigors especially. That's definitely what I recall.
And it was all in a short period of time, too. I mean, as terrible as all of that sounds, Rod recovered, I think, probably on the quicker scale, if you were to speak with, the doctors that give the CAR T therapy. I mean, I do think that he recovered pretty quickly once everything was under control.
Yeah, my medical care was exceptional, along with my caregiver.
Well, thank you. And to continue on the side effects, I'd like to ask Dr. Hickey or Dr. Hay, do we have any progress on that thing, meaning that are we having less side effects now that the drugs have evolved a little? Is it a bit different? Is my question.
Yeah, sure. I guess I'll speak to that just since that's a lot of what I deal with is those toxicities. So I would say we've made lots of advancements since the early days of CAR T. In the very early days when the first person was treated with it, we didn't even know what some of these toxicities were. We've characterized them better. We've made guidelines of how to treat them. We have a stepwise approach that based upon how severe they are, using various different medications to treat them. I think one of the biggest changes is that we identify the toxicities a lot earlier than we used to a long time ago, not that many years ago, since CAR T hasn't been there for very long. But and we have some prophylactic approaches as well that we're using. I would also say that there are things in development of ways, again, as I mentioned, to armor the CAR T cells or change them or change the actual structure of the CAR to try to decrease some of these toxicities in the future. So there's definitely more to be done. We're by no means, have made this as simple as possible from a toxicity perspective. There's a lot to be done, but there have been definitely progress over the past few years in how we manage these.
Thank you. Dr. Hickey?
Yeah, just to add on to that, what I would say as a center who's looking to hopefully have a CAR T program in the upcoming years, a big part of the management of the symptoms is helping either recognize them early or trying to prevent them. And so, in order to have a center, you need expertise and a collaborative effort with an ICU team and a neuro team, and being able to pick up on the ICANS and the CRS quite early on. And so, that's where some of the challenges lie, even for us trying to get a center up and running, is having everybody, with that early expertise when you're getting patients started, when it's not recognized, seen regularly.
Okay, thank you. So I said we have a lot of questions, and I'm going to ask only one last question because we're already on time. But maybe this is a question that is very fitting for these times. People are saying that most of the CAR T treatment production is done in the USA. Are we planning on manufacturing some of these treatments in Canada? We know that, for example, CARVYKT is not being funded. So would Canada develop its own CAR T therapy? What's the future of CAR T production in Canada?
So maybe I'll take a jab at that, since I do some biomanufacturing and lead 2 different labs in Canada that actually do make CAR T cell therapies for patients on clinical trial. So definitely we have expertise here in Canada where we can do this. It tends to be centered within academic centers, so we don't have a commercial source of CAR T. So there's no company that's decided to make a CAR T center here. For various different reasons, most likely because the US is the larger partner, and when you have to have only a few different manufacturing sites within a continent, you're probably going to center them in the US, and a lot of these companies are US centric. So there have been, efforts to make various different CAR T cells. I've run a trial with a CD19 CAR with Natasha Kekre, who's based in Ottawa, actually, and has treated probably a lot of these Newfoundland patients who we've been chatting about. So we run a trial together. And then we have a CD22 trial, which is something that could be used against B cell cancers after CD19 CAR T cells haven't worked. So we have an ongoing trial of that. And there's a hope for other different projects in the future for various different cancers. So I would say there's a lot of hope to try to make a Canadian growing approach, but there's nothing commercially available is the way I would end it.
Okay, thank you. Yeah, well, so that's it. Thank you all for these wonderful questions, and thank you, obviously, to our guests for the answers that complement this presentation perfectly. If I can have your attention for 1 or 2 last minutes. Next slide, please. Cell Therapy Transplant Canada is inviting you to their annual conference in Ottawa-Gatineau, especially on the patient-focused session that will be held on April 30th. You can find more information about this at cttcanada.org. Next. Several webcasts will be offered by the LLSC this spring. On April 24th, we'll talk about genes and blood cancer. In May, we'll offer Myeloma Week, and in June, we'll offer Lymphoma Week. Details are still being discussed, and registration is not open yet, but stay tuned on our event page, bloodcancers.ca/events. Next. This event was made possible thanks to the support of Johnson & Johnson and Bristol Myers Squibb. Next. Please remember that we are here to support you. Contact us. Please note that a short survey will be sent to all participants after this presentation. We thank you for taking a moment to respond, as it helps us plan future events. Thank you all for being with us today, and take a good care of yourself.